Hello, everyone. Welcome if you're here for the first time, and those of you who are joining us for another day, welcome back. We are here for day 2 of NaRCAD's first annual AD Virtual Summit. We're going to get started. This will be a refresher for those of you who joined us yesterday. I'm going to speed through these so we can get right into the juicy stuff. So we're here to think about a deeper understanding of our impact on patient care. Here's our home team. Home team, can you wave? We've got Mike, Jerry, myself, Anna, and Anshul. Happy to be hosting for the second day and to invite you to relax and get ready to share your thoughts and take in all the good stuff that we have in store for you. Quick reminder, this fall we will have our 11th annual International Conference on Academic Detailing. We are back in person for the first time in 4 years. The last 3 have been virtual, as many of you may know. We are so excited to invite you back to Boston. Please know that proposals are still being accepted through July 1st. Also, you can email us and say, I really want to submit a proposal, but I don't have results yet, or I'm not sure what's going to happen. We can still find a way to see if you might be ready by November. Our registration will open August 1st, and Anshul just popped a link into the chat box for you to explore more on our conference series page. As you may remember from yesterday, we have this amazing page that Anshul put together called the AD Summit Hub. It's where all the juicy stuff is. So if you missed anything from yesterday, if you missed anything from today, or you just want to review stuff, you can go on your phone or on your computer to the link that Anshul's about to drop in the chat box. You'll get recordings, materials, and it'll be up live very soon. So do check that out. And you also don't have to take notes because everything will be there. Quick reminders for housekeeping, please put your video on. If you don't consent to having your video on for this recording, keep it off, but we would really, really love it if you could stay on and make this as interactive as possible. So do that within your comfort, please. Please make sure your full name is correct on your Zoom window with your pronouns if possible, if you're comfortable. The first time you use any acronym in the chat box or when speaking, please explain what it means with the exception of AD. Hopefully we all know where we are with that. Folks come from all different backgrounds. We really want to make sure everyone's on the same page. Don't forget, we'll make sure you can all stay in touch with a shared contact list. If you don't want to be on that list, you can let Anshul know. And of course, if you have any tech issues or need support, please directly message Anshul on Zoom or pop her an email. This is what the screen will look like when we have a discussion segment after and during presentations. You'll also want to check out our Summit program book. It is so awesome. Everything's clickable. You can learn more about presenters. There's so much good stuff in there, especially there are blogs that focus on the patient voice. So we've curated those. They're phenomenal. They're written and curated by Anna Morgan Barsamian. And so please do check that out. All of the innovative stuff that we have going on in our program is just truly awesome way that we've been looking more at some of the stuff that you all have been asking for and that the direction the field has been going in. So we're looking at all kinds of stuff. Along with the patient voices, today we're going to learn about AD for sex positivity, gender affirming care. We're going to keep encouraging clinicians to break down those silos where they feel kind of ensconced in their own bubble and connect them to community initiatives. We talked yesterday about the care of formerly incarcerated patients. Today, we'll talk a bit more about restructuring care delivery systems and patient inclusivity, all good stuff. We have hands-on workshops today. Yesterday's were a blast. Today's look like this. If you are a newbie or you just want to have some fun, join myself and Dr. Avorn to build your own program. So it's a choose your own adventure. You get to create whatever you want, and we will judge it, not harshly, and ask you some challenging questions about how you'll make it sustainable. We also have an awesome 201 that will be about the story of program impact, which really centers on how do you evaluate and assess the impact of your AD program. 301 is real-time design, where you'll learn how to educate clinicians with compelling visual aids. Many of you see what they look like online or have made great efforts in this direction. We will show you how to do it on a budget and really learn from other people so you don't have to reinvent the wheel. And last of all, this content I mentioned a moment ago in 401, you'll learn how to empower clinicians to feel more like they are connected to other care services that will support the whole patient. So again, we're going to be highly interactive. We're going to look to you to lead and be creative. We're going to let you walk away with tangible virtual skill building worksheets and products you make together. We'll be networking, and you'll have plenty of time for peer learning. So here's what's going to happen today. We're kicking off now. We're going to go into an amazing best practices spotlight. So great. Can't wait for you to see it. We'll have a break. We'll then have our workshops, another break, and then the NaRCAD team will close up asking you to help us write scripts in response to clinicians who may exhibit implicit bias during a visit. We'll give you 5 minutes, 10 minutes rather, to wrap up and share your evaluation thoughts. All right. So without further ado, our best practices spotlight, leading with the patient experience. I am going to turn it over to Anna to introduce our first speakers. Take it away.
Thanks, Bevan. Thanks for kicking us off. So we'll have time for questions after each of these presentations. So get your questions prepared, add them to the chat box throughout the presentations, and we will get to them. I am beyond thrilled to be able to introduce our first speakers today from the San Francisco Department of Public Health. We've worked closely with the San Francisco team for more than 5 years and are excited to have Sophia Cass and Jessica Bloom with us today. Sophia is the program coordinator for the Capacity Building Assistance, or CBA program at the San Francisco Department of Public Health. Before coming to the United States in 2015, Sophia spearheaded a World AIDS Day campaign with the only sexual health center serving the underground LGBTQIA+ community in Beirut, and spreading awareness and shifting narratives away from rigid societal taboo and stigma. Sophia also has worked with the Transgender Law Center's Positively Trans program to combat inequities and discrimination. Dr. Bloom is the Deputy Director for the CBA program. She serves as a lead CBA specialist in the provision of technical assistance for health departments and CBOs in the West region of the United States, in the areas of non-clinical HIV testing and prevention services for HIV-negative people. She also provides medical care for people living with HIV and people seeking HIV prevention services at the San Francisco General Hospital Ward 86 clinic. Sophia and Jess, it is my pleasure to hand the mic over to you both to share about affirming care for transgender and non-binary people.
Good morning, everyone. Good afternoon. Thank you so much, Anna, for the introductions. Folks, before we start, just a quick reflection that 15 minutes are far from being enough time to cover a topic like gender affirming care that is multifaceted and very nuanced. So our hope from this really is for it to be a conversation starter, to stoke your curiosity. And we're sharing a lot of resources, actually, whether at the end of this or even the pre-reading material that our colleagues at NaRCAD already shared, which we hope will be useful to you all. Next, oh, and we have no disclosures to declare. Thank you. So let's start with this quick temperature check. How comfortable do you all feel discussing gender affirming care with your clinicians? You should probably see a Zoom call on your screen, so please go ahead and submit your answers.
Yep, that's coming right up. So
Thank you, Bevan.
just to narrate, we have 55% of folks are saying they're comfortable. Another 20 say very comfortable. 11% say very uncomfortable, and around 15% say uncomfortable. So they're moving back and forth a little bit, but it seems like comfortable is in the lead between 50 and 60%. So keep on typing those in. It looks like everybody answered, and I'm going to end the poll.
Awesome. Thank you so much, everyone, for answering, and Bevan for helping us with the poll. Comfortable is 59%, so this should be an easy job. And for the very uncomfortable and uncomfortable folks, we hope that this will help you a little bit on your journey towards comfort and discussing this topic. All right, next slide, please. So why are we discussing gender-affirming care? What need is there for it? Let's first start by quickly looking at what the term gender means, because a common misconception whenever gender comes up is that it's something natural or biological or physiological, genetic, you name it. When in fact, and as you see by the definition of the WHO, it's a social construct where, societies have divided people into groups, assigned roles, norms, behaviors to each group. But more importantly is that these groups and these social constructs change from culture to culture, from society to society, and they have changed within the same culture across history and across time. In fact, on nearly every continent and for all of recorded history, cultures have recognized, integrated, and even revered more than just two social constructs or two genders. Some third gender examples, if you want to look them up, the Muxe people in Zapoteco cultures of Oaxaca, southern Mexico, the Mahu people in Native Hawaiian and Tahitian cultures, or the Two-Spirit folks in Native American cultures, and Hijra individuals in South Asian cultures. Next slide, please. So this infographic does a very good job at summarizing and giving a visual interpretation of the different terminologies relating to sexual orientation, gender identity, and gender expression, or what you see on the slide called SOGI. Unfortunately, we won't have time today to go over all these definitions, but again, as I mentioned, they're covered extensively in the pre-summit reading material that our colleagues at NaRCAD shared with you. But there's two main messages that I would like you all to take away from this slide. The first one is that when it comes to human diversity, no two humans are alike. Every person is completely and truly unique, be it who they are, who they love, how that person shows up in the world, how they express their different identities, and especially that each person has a completely and truly unique footprint in the world, and they have a contribution that no other person can bring. The second message is to know that even our best efforts to make sense of this large and galaxy of limitless possibilities that is the human diversity, these efforts will always still fall short of what this diversity truly is. And so, we try to simplify, categorize, label so we can understand better, but just a call to stay open to learning and to believe people when they tell you who they are. Next slide, please. Unfortunately, transgender, non-binary, gender-diverse populations in the US are continuously, if not increasingly, facing significant bias, stigma, discrimination that have had a detrimental and are having detrimental effects on our health and well-being. And they prevent us from accessing much needed healthcare, stable housing, employment, education, you name it. We also know very well that trans people of color, Black, Indigenous folks take the brunt of these experiences. If we just look at healthcare access on this beautiful infographic that was put together by our colleagues at the Denver Prevention and Training Center, we can see that 1 in 4 transgender and non-binary people reported harassment in healthcare settings. In one of my previous jobs, which Anna mentioned, Positively Trans, as the Transgender Law Center, we actually did a national needs assessment for transgender people of color living with HIV, only to find out that people delayed care 6 months because of discrimination in healthcare settings. And again, these were people living with HIV and they knew their status. And so yes, person-centered care, affirming healthcare is a desperate need to start bridging these ever-widening disparities, which you see listed in front of you on the slide. All right, everyone, next slide, please. So, thank you. So how can you as detailers promote gender-affirming care with your providers and clinicians? Next slide, please. Thank you. So first, if you can, that's okay. So
Can you go back?
thank you.
There you go.
Yeah, thank you. So whenever we talk about creating a gender-affirming clinical environment, we should know that there's 4 main facilitators that play into making that a reality. And you as detailers, your asks to clinicians and providers will generally fall under these 4 categories as well. If you can please click, Bevan, thank you. The first ask is for providers to have an approach to care that is based in the social determinants of health of the transgender and non-binary patients. Here, we're not asking the provider to solve all of their patients' problems, but we are asking the provider to get to know their transgender and non-binary patients' lived experience and to take into consideration, their holistic needs and particular circumstances in any treatment plan or modality they are going to be putting forward. If you can, please click one more time. Thank you. So this is also where you as a detailer will need to use the data and the resources that you have at your disposal to tell the stories of transgender and non-binary people and educate your providers about their trans patients' lived experiences. This is also where you are encouraged to find ways to support your providers by helping them maintain updated lists of and databases of resources and referrals at the clinic so that they can meet their patients' different and holistic needs, as well as connecting them and their staff with relevant professional development opportunities so that they become more and more familiar with the social determinants of health of their transgender and non-binary patients. Dr. Bloom, I'm going to pass the mic over to you. As a physician and a provider yourself, can you share with us what would make this message resonate with a physician or a provider?
So thank you, Sophia, for the wonderful background so far. I think that this message is really important, and one way that I would frame it for clinicians is thinking about person-centered care. So particularly in primary care, clinicians are aware that we need to understand the whole person to be able to take care of their health. So for our transgender and non-binary patients, understanding the social context, the historical, political, economic forces that are affecting our patients' lives is crucial to be able to provide that person-centered holistic care. So I think that framing of person-centered care can be really helpful, particularly in a primary care setting.
Thank you so much, Dr. Bloom. If you can please backtrack, I hate to ruin the element of surprise. Thank you. So the second ask for your physicians and providers is to use language that is affirming and non-gendered. In fact, using correct language, again, along with using people's correct nouns and pronouns, is one of the first ways your providers and their clinics can start to create this environment of safety. We talk about emotional, physical, and psychological safety for everyone, really, but particularly for transgender and non-binary patients. Again, here, there's many language or SOGI one-on-one trainings that you can connect your providers with. Dr. Bloom, back to you. What would make this specific language ask resonate with a physician or provider?
So when it comes to affirming language and how to care for patients in an affirming way, I think about some clinicians may have an objection that they feel uncomfortable or inexperienced with how to do this correctly. So I think one way to deal with that objection is to say, you can simply ask all of your patients, what name do you use and what pronouns do you use? and be ready to learn from your patients and to apologize and move on if you make a mistake, and make it that simple for clinicians who have that objection.
Thank you so much, Dr. Bloom. If you can please click, Bevan, thank you for helping us today. So the third category of asks will be to put in place organizational systems that support both creating and sustaining these safe and affirming environments. Here, it's important to educate your providers that gender-affirming care doesn't just happen in the exam room, but actually it starts at the facility's entrance. An affirming patient experience will actually include everything that the patient is exposed to, from signage to visuals throughout the facility, to clinic policies, particularly around bathroom use and space use, as well as anti-discrimination policies, to also to interactions with frontline staff, to intake forms, electronic records. Dr. Bloom, when it comes to organizational systems, what would make these particular asks resonate with providers?
I think this is a really important topic in terms of developing gender affirming environments, and it can also be disempowering for clinicians, many of whom work in large systems where they don't control a lot of these aspects. So I would encourage detailers to work with their clinician on identifying one or two areas where they do think that they could have an impact and take action. Something as simple as working with front desk staff or updating forms that are easily updated in their clinical setting.
Oh, you're on mute, Sophia. So we just have Sophia plugging back in for a moment and trying to get her audio going. In the meantime, you can be thinking about questions for the chat box. Sophia, do we have you back? We do not. In the meantime, Jess, would you be able to keep on going until Sophia can figure out what's cooking with technical stuff?
Sure. So just to add on to the discussion of organizational systems, often a lot of these policies in larger healthcare systems, physicians have the opportunity to impact through attendance on committees or communication with their clinical leadership. So that's another, particularly for clinicians who seem more on board with wanting to create gender affirming environments, that's another option that you can discuss with them.
I think we might have Sophia back. Is that correct? All right, we'll keep on going. Back to you, Jess. Do you want me to move forward?
Sure. So maybe you can go to the last one. So the last bullet here is outreach and meaningful community involvement. So ensuring that the people who are most affected, meaning transgender and non-binary folks, are included in brainstorming about how the clinical environment can be made into a gender affirming space. And that can take various forms, but this I think is an opportunity for detailers to act as a resource with clinicians as well. So anything from, if there are folks who you may be aware of who want to, transgender and non-binary folks who want to participate in a clinic's patient advisory board, to having lists or resources of community organizations that serve gender diverse populations that clinicians can refer their patients to. I think this is a really great opportunity for the detailer to act as a resource for their clinicians. And if you move on to the last, so I think the final point here is just trying to move away from ideological debates. So the messaging here really focusing on stories, on the stories of transgender and non-binary patients, as opposed to getting into kind of theoretical debates, is really a much more effective way to frame this discussion.
Thanks, Jess. Shall I move forward, or do you want to take a moment to perhaps answer a question? What do you think?
Sure. Do we have a question?
Well, if folks have questions about this really rich slide here in
Hello?
terms of, oh, do we have Sophia back?
I joined from my phone. I'm so sorry, y'all.
Beautiful. There you are. No worries. Jess did a wonderful job, and I have
Thank you,
learned how to
doctor.
stall. So we worked together. So let's move on to the next slide. This is over to either of you.
So thank you so much, Dr. Plume, and everyone for your patience. These are just the resources that we use to develop our slides. And hopefully these resources, as we said in the beginning, will be useful to you all in your detailing programs. If you can please keep going. One more time, please. Awesome. So a quick note about us. We are a capacity building assistance provider based at the San Francisco Department of Public Health, and we provide technical assistance with two focus areas: non-clinical HIV testing and prevention for HIV negative individuals. If you are interested to know more, please visit us at www.getsfcba.org, or you can email us at get.sfcba@sfdph.org. All right, thank you, everyone.
All right. Well, that was, as you said, a lot to cram into 15 minutes. I don't know how you did it, because this is a topic that could certainly be talked about for many, many days, and then some, as things continue to change and grow. We do have a first question here. Jessica Kulo says, do you feel like providers are more open to talking about gender affirming care when it's first framed in a more traditional sense, like men seeking breast tissue reduction surgery or women seeking breast reconstruction surgery after cancer treatment? That's a great question. I'm going to throw that to you, Sophia.
I would say, I used to work as a pharma rep previously, and the needs assessment part and getting to know your provider is crucial here to answer your question, because you also want to level with the person that you are talking to in general, but particularly with your providers, to make sure that they can relate to the stuff that you are hitting the right notes for them as well. So if that helps, then yes. And one more thing, actually, take it in small incremental wins. So sometimes as a pharma rep, the only win was for me to get to that doctor to see me again. Sometimes the only win was for them to open up and maybe start talking about this. So, these small wins build up eventually, and will get you where you want to get. Does that answer the question?
It seems like it does. Jessica, you're welcome to sound off in the chat box. And then, there's so many ways that we could get in deeper, but I really liked that question because it talked about what are the smaller steps that folks can wrap their heads around first. So I found that a really fascinating question. I'm going to turn it over to my colleague Anna to ask a question from our home team before we wrap up. I'm sure people in the audience will have many questions for days to come. So folks, keep them coming, and whatever we can't get over to Sophia and Dr. Bloom, we will curate and pop over to them. Take it away, Anna.
All right. Dr. Fisher asked, in some regions, the environment for gender affirming care has become very difficult, including laws, regulations that might limit that care. Excuse me. How do you advise detailers working in those areas to engage with clinicians who may be apprehensive?
Dr. Bloom, do you want to take this, or if not, I can take this?
I can start out, and then if you'd like to add anything. I think in response to the previous question as well, I just wanted to highlight that Sophia's background today really intentionally focused on creating gender affirming environments in clinical care, as opposed to sort of medical or surgical treatments that may be offered to gender diverse folks. And I think that's really not an issue for a lot of these laws. So I think it's a great place to start, because there's a lot of focus on that, but the reality is that the majority of health concerns for transgender people, just like everyone else, are not related to their gender affirming medical needs, and we want to make sure that they get all of the healthcare they need. So just for people to feel comfortable walking in the door is a really important and vital thing that doesn't relate to those laws, generally speaking.
Sophia,
also,
we have one more minute if you'd like to echo that or add anything new.
Yeah.
Thanks, Jessica.
Thank you, Dr. Bloom. And actually, one of my last talking points was about the ideological debates, right? Because, you know, a lot of the conversation happening today, and particularly relating to these bans or to the general environment, is not happening in the science realm. You know, studies have shown over and over again that providing gender affirming care improves the emotional and physical well-being of gender diverse both youth and adults. So a lot of what's happening today is actually in the realm of rhetoric and the realm of narrative. And to counterface anti-trans stories and anti-trans rhetoric, we need to tell more stories of, you know, the lives of transgender people and gender diverse people. And to do that, as retailers, you need to also first familiarize yourselves with the daily lived experience of trans folks. So tell stories, people.
Thank you, Sophia. We lost you a little bit in terms of sound. I tried to capture some of this. So if you'd like to add any more of the thoughts you just shared to the chat box so we can make sure everyone got them, that would be delightful. Thank you both so much for being here. There's your voice. Anything else you want to add?
No, thank you. And technology, by now we're all used to Zoom, right? So
we are, but we know that this is just a dangling carrot for folks to go and seek out more great information from both of you and from your programming. Thank you so much for being here, and we will look forward to future conversations with you. Thank you so much. We're going to switch on over to Anna introducing this next presentation.
Thanks, Bevan, and thank you, Sophia and Jess. We really appreciate it. Our next presenter is joining us from Arizona. It is my pleasure to introduce Rocco Cook, Public Health Detailer and Public Health Detailing Program Manager at the Detailing for Improved Sexual and Social Health, DISH program within Arizona State University. Rocco began working in the field of HIV in 1994 and is a community leader with over 15 years of experience implementing prevention and care programs in Arizona, Ohio, and Kentucky. Rocco has been living with HIV since 2002 and is passionate about improving sexual health for all communities. Rocco is going to share about his team's adventures in academic detailing, specifically on their work on patient-informed communication on sex positivity and HIV prevention. Thank you for being here today, Rocco. Without further ado, I will turn it to you.
All right. Thank you so much, Anna. I really appreciate it. And thank you everybody for being here. So I'm going to jump right in. I don't have a ton of time, and I have a lot of slides, so we're going to get through them as best we can. But a couple of acknowledgements. Our project is funded through the Office of HIV and Hepatitis C Services at the Arizona Department of Health Services, and through a CDC grant and some of the COVID-19 workforce development funding as well. So you can go on. I have no disclosures. ASU, where we are housed, is at Arizona State University Southwest Interdisciplinary Research Center, which is part of the Watts College of Social Work. And it is a unique partnership between the university and the Department of Health Services. Department of Health Services has a lot of hiring restrictions. And so being able to do this through the university gives us a lot of freedom to be able to do a lot of the work that we do. All right, so here's our team. Just to kind of give you an overview, Dr. Amaya is our principal investigator. I'm the program manager. Dave Watt, who you'll see probably coming in and out behind me here, is one of our detailers. And Dr. Kevin Carmichael is also one of our detailers who happens to live in Tucson. We're located in Phoenix, but we do cover the entire state of Arizona. And so So a few things before we jump right into this. One thing is that this is obviously not a comprehensive overview of utilizing sex positivity approaches or status neutral approaches when we talk about HIV prevention. These are just some thoughts that we put together as a way to get the conversation going about how we could do a better job in our healthcare settings, and then also as detailers and working with our clients. So, okay, next slide. All right, so what is DISH Arizona or DISH AZ? So it's Detailing for Improved Sexual and Social Health in Arizona. We included social health because we also talk about hepatitis C quite a bit. And also because it's not only sexual topics that we're focusing on, but also sort of the social impacts of community and the interplay between those things. Our three main points for how we do detailing, and this is all very specific to what we do here. We've been going for about a year, and so we don't have all the answers, but we do have some kind of unique approaches, I think. So our focus is to connect, educate, and support. So our big goal is, first off, to reach out and develop a network of champions. You know, Arizona is a mostly rural state. Like, there are two major cities in Arizona, but otherwise it is very rural. And we want to be able to connect and support those folks who are out in the field, who just need that information and need that education and support. So it is much more about the relationship for us than it is about the educational knowledge side of it. Well, that does play a part as well. Okay, you can go to the next slide. All right, so what do we do? So just a little background about our program, because I think it'll make more sense once we get to the approaches of how we look at patient-centered care and what that looks like. So to date, we've worked with 15 different clinics and one hospital. Last quarter, we detailed 83 participants, and mostly in one-on-one sessions, but a few times we're in small group sessions as well. And so we're still getting launched and sort of together in our program, but we've kind of hit the ground running in a lot of ways. So we do presentations as well. A lot of times, in order to get our foot in the door for our academic detailing sessions, we want to be able to show them that we know our stuff. And so some of that has to do with presentations. We are sort of on the forefront of MPOX in the state. We are working very closely with county health departments and the state health department to implement some MPOX guidance and messaging. We also focus on do's and don'ts of HIV testing, HIV basics, status neutral approaches, prevention specialist education. We work closely with AETC, motivational interviewing, hepatitis C testing, gender expansive care, to locations around Arizona. So that's kind of a summary of what we do. Next one. Next slide. There we go. Thank you. So we do statewide and national education as well. So MI training is a big focus of what we do. Again, that's more of the approach than the topics, right? So, but we want to show people and discuss with people how to have those sexual health conversations in a way that is non-threatening, that engages thank you, motivational interviewing, yes. That is engaging and incorporating the values and thoughts of the client or patient within their care program or care plan. So we also focus on cultural humility. We attended the Trans Health Summit and the Biomedical Summit, which I want to talk about here in a little bit. Another aim of ours is to disseminate information. So as we come up with some of these ideas and as we focus on sort of how we can implement them within our own program, then we want to be able to tell others about what we're doing as well. So I will share with you a little bit. Last year, we went to the USCHA, the United States Conference on HIV and AIDS in San Juan. Fantastic conference. I recommend it. But one of the things that I overwhelmingly heard was a large frustration of, well, what are we going to do about providers? Who's educating the providers? And there was, it seems to be a lack of information about academic detailing specifically, but also just how to do provider education in general. So we wanted to make sure that everything that we're doing is engaging in the conversation with those who are doing this work in the workforce. So next slide, please. Okay, so what sort of materials do we use? Currently, we have 4 materials. We are about to release or more, which we're very excited about. So stay tuned for that. Promoting sexual health, a guide for clinicians. So that's how to start the conversation around sexual and social health. Prescribing PrEP at your clinic. We talk about long-acting injectables. We talk about 2-in-1, that sort of thing. Rapid Start and hepatitis C. All right, next slide. We also work on supplemental materials and including like HIV testing do's and don'ts. And these are all interactive. So when we work with a client, let's say a federally qualified health center, for example, we'll go in and work with them to present some ideas that we have about supplemental, about some of these supplemental topics, but also have them engaged in updating the document. So we use a Google Doc. We ask them to get on their laptop and go ahead and include ideas that they may have as well. So it is they're living documents that we utilize in our academic detailing sessions. One of the things that I should also say up front that I don't think I did is that when we talk about providers, we don't just talk about medical certified providers. We're also talking about, so we're talking about MDs, and DOs, of course, but also NPs, nurses. We're talking about testing, outreach testing. We're talking about navigators. We're talking about front desk staff. So because what we've realized in our early tenure in this is that it doesn't change anything if we just go talk to one provider at one clinic. Yes, they might be able to write a few more prescriptions, but if they don't have the support throughout their entire clinic to be able to provide this sort of messaging and this sort of changes and improvement in sexual health, then it's not going to really have that much impact. So, all right, move on to the next one here. Coming soon, we do have gender expansive care that we spend a lot of time. We have hired a consultant who has lived experience with gender expansive medical care, as well as lots of lab experience and that sort of thing. Our hope is to eventually bring this person into our fold as a detailer, because we recognize the importance of sort of following up on what Sophia was talking about earlier, the importance and need of making sure that that care is able to continue to be provided regardless of what legislative acts are going on around the country. All right, we're also focusing on mpox, syphilis for men who have sex with men, congenital syphilis. If you don't know, Arizona is #1 in congenital syphilis, unfortunately. So it is a large focus of ours. Even though our funding is specific to HIV, we do see the connection there with congenital syphilis. And then substance use disorder. All right, go on. There is a QR code there, the serving dish. So we took the dish theme a little far, which is okay, I guess. So every week we put out a newsletter that is all the latest and greatest information about what's going on in the field of sexual and social health. So regardless of whether it's mpox or syphilis or whatever, you'll see all of the latest articles that have been published in the last couple of weeks in this newsletter. I encourage you to use the QR code to sign up for it. Dr. Kevin Carmichael is our lead detailer down in Tucson, and he's the one who puts that together. He does a fantastic job. So, all right, that's enough plug for what we do. So moving into the idea of, into the idea of sexual health and the 5 Ps, right? So we all know the 5 Ps of sexual health conversations, right? Partners, practices, protection from STIs, past history of STIs, and pregnancy intention. But let's move to the next slide.
And not everybody may know that. So for those of you for whom it's brand new, enjoy the now 8 Ps.
That's right. Thank you so much. I appreciate that, Bevan. So now enjoy the 8 Ps. So we realized that we put together our materials and we're like, oh my gosh, this is so comprehensive and it's going to be really great to have these conversations. And then as we went to conferences and started learning some things that we were in the field, we've both been in the field, all of us been in the field for a long time, but we hadn't really considered these 3 ideas. So one of them is preferences and focusing on, what is it that a person prefers in their sexual engagement. Also talking about partner violence as an important conversation in trauma-informed care. And then the final one is pleasure, which is the biggest aha moment. So let's go on to the next slide. All right, so how do we do it? So we talked about the things that we do, right? Presentations, one-on-one academic detailing. But we also recognize that it's important to have sort of our approaches lined out. Like what are our talking points as we go in and talk about how to have sexual health conversations? So what is the approach that we're taking? And two big ones here, status neutral. We've actually presented quite a bit on how to create a status neutral environment. Where it actually gets blown up on the next one. So
My bad.
you're good. So status neutral, which is to say that everything begins with an HIV test, but after that, it can go one of two ways. And we need to make sure that we are providing the same level of care for people who are HIV positive as we are for people who are HIV negative. And so a lot of it goes into that regarding funding and all of that sort of thing in separate streams, but the idea of integrating those two things so that we can provide HIV testing, STI testing, hepatitis C testing, and linkage to care, so that we are providing an equal footing for everyone who is HIV positive or HIV negative. Everyone has a part to play, regardless whether it's PrEP, PEP, or Rapid Start. All right, the pleasure principles. So we've had kind of a big aha moment. So you can go to the next one. A couple of other things. We do focus on social determinants of health as a big part of what we do. And so when we do academic detailing, we bring that into the conversation with the providers. And we talk about, okay, let's talk about who your patients and clients are. Mostly we work with federally qualified health centers. So for us, it's not really a private practice situation. And they are already reaching a lot of folks who might fall into these social determinants of health, recognizing that gender and sexuality is a big part of that. And then also going in with an informed idea of gender expansive care and how to make sure that the clinics are welcoming and open to providing care for all people. Okay, next slide. All right, so why focus on new approaches? Pleasure is the focus that we're going to talk about today, and that is assuring that all individuals have access to full sexual and reproductive health and rights, prioritizing joy, safety, and consent over, well, what did you do last month? Or what were these things that you did, right? So focusing on the future and providing them the tools to be able to have the pleasure that they're seeking. So pleasure is recognized as a key component of sexual health and well-being. We all know that sex is fun and sex is good, right? So, but a lot of times in our prevention programming, we don't really pay attention to that. Some examples of that are down at the bottom, very fear-based approaches. I will also go out on a limb and say that sometimes we can be very shaming in the way that we approach harm reduction. And when we say any positive change, we tend to frame that positivity, that whatever that positive change is, based on how we want the behavior for that patient to be the next time that we see them. So when we say any positive change, we're actually talking about reducing your drug risk or reducing the number of partners or using condoms. And so that falls within a framework that is very biased, and it doesn't really necessarily take into account what it is that the patient wants. So go ahead and go to the next one, please. All right, so we had a big realization. We went to the Biomedical Prevention Summit. I heard Dr. Daskalakis speak, also known as Dr. Disco Lights, who headed up the MPOX campaign. I heard him speak very eloquently about the idea of taking pleasure and focusing on pleasure-based principles as a form of prevention, as opposed to these fear-based messages. And so changing the conversation. So what if we stopped asking clients about risk? How many sexual partners did you have in the last 30 days? We need to know that information. Versus, what kind of pleasure would you like to have? What kind of sex would you like to have? And how can we provide the tools to make sure that you do that safely? So it changes everything and turns it on its head. So that was a big aha moment for me. So next slide, please. All right, so by asking the questions differently and focusing on pleasure as an aspect of sex, as well as drug use, or as well as all of the other things that we do, and we address the health for, we want to reduce the stigma of discussing and identifying people by their risk behavior. Oh, this person is a high risk person. This person has many sexual partners. So we sort of categorize them and put them into this very shaming and stigmatizing place, as opposed to developing a plan with them, utilizing motivational interviewing, hopefully, to get them around to decide on what is right for them so that they can experience what they want. Viewing patients as the sum total of their risky behaviors minimizes their experiences and frankly minimizes their humanity. So what if we asked, how can I support you? So we talked about that. All right, next slide. Moving from risk-based to pleasure-based. So focusing on the joy of sex and healthy relationships and consent and rights as a part of sex, rather than the negative aspects of like, oh my gosh, you didn't use a condom every time. So we can potentially destigmatize and heal trauma that may have already happened before. If patients know that they are truly accepted and their behavior is celebrated, hopefully it'll be easier for them to engage in conversations in the future. So then you build a trust relationship with that patient that is going to be ongoing and incorporates their views on what they want to happen next. All right, next slide. I'm not going to go too into this. When I was doing my research and a lot of the things that we've been focusing on, this was the best slide that I could find that really focused in on those pleasure principles. The very first one is be positive. So coming in with a sex positive focus of saying, whatever it is that you're doing, as long as it is safe and consensual, then you are good to go. And let's talk about that. And then focusing on rights. We have a tendency to say, well, your sex is risky, so therefore you don't have the same rights that someone else does. And that is really false thinking, I think. So I think that we can move the needle and get outside of that thinking. And then finally, thank you, go ahead, that's fine. This is also from the Pleasure Project, and it moves us away from the idea of fear-based messages and abstinence, and this is the only way to do it in order to reduce your harm, into a place of defining pleasure as sexual health and sex and sexuality and the joy and well-being of healthy relationships. So I'm not going to go too far into that slide. It's fantastic. I recommend checking out the Pleasure Project. If you work in health services, where the rubber meets the road, respect clients' choices, understanding that their life is their life and they're going to live it in the way they see fit. And it's our job to work with them through that process. Work to feel comfortable as a provider to discuss sex and sexuality. It may be uncomfortable to talk about some of these things, but the more we do it, the more we get used to it, and the more we're able to do it better for the next person. So, and then before talking about sex and pleasure with others, think about what our own boundaries are and what we're comfortable sharing and not sharing. It is, as we all know, it is really important to have those boundaries, including in academic detailing and talking about our own experiences. For example, I talk about being HIV positive, but I don't always go into the details of what that might mean for me. I do it depending on, based on the relationship that I have with the other person and what is going on at the time. So situational. All right, next slide. Creating a safe and non-judgmental environment. That can be what it looks like when you walk through the door. That can be the conversations you're having. That can be what types of relationships you have. Being open to listen to clients' concerns and needs and realities. And then explaining that you can provide healthcare information about the benefits and risks of sex so they can make informed choices. So it's about their information and their choices, not about ours. I love the don't yuck someone else's yum. That's fantastic. So, all right, next slide. So where do we go from here? So DISH AZ is going to continue to reach out and connect to federally qualified health centers, especially those who received ending the HIV epidemic funding. And the reason that's important is because there's a huge gap of information. They received a lot of funding. They hired a lot of PrEP navigators. They hired a whole bunch of people, and they didn't really provide the training that was necessary. And AETC does a fantastic job, but those are group level interventions or group level presentations. They need the one-on-one care and support. Connect with primary care providers and healthcare staff across a clinic. Building a strong network of providers who are committed to improving sexual health and incorporating the how we do it into what we do. So what we do is sexual health, what we do is HIV prevention and talking about those things, but it's important to remember how we do that and the framework that we're using when we do those sessions. So remember, it's all about improving sexual and social health for our communities. All right, next slide. Finally, there's our newsletter, a QR code at the end. I know I went over, I apologize, but thank you for listening to me speak very quickly. And I think we might have a couple of minutes for some questions.
We do have time for one question. Dr. Fisher, I think you had something up your sleeve.
I sure do. I was yeah, thank you, Rocco. That was great. Good to see you again. this is this sort of the sex positive approach, I think, for for clinicians in primary care, we get very little education in our formal training about sexual health. I mean, even I realize, sadly, we're getting to the stage where I'm one of the older people on the call, but even so, even in the younger generation, it's just not well covered in our medical, our nursing, our pharmacy, our other curricula. So, we've always seen this struggle. When people don't know, they sort of, get in a little bit of a defensive shell sometimes and say, oh, I can't do it, and, we tend to be, in healthcare, a sort of conservative and sometimes sort of moralizing field in unproductive ways. And I'm sure I'm telling you things you see all the time. It's like when we started working on prep detailing projects, it was all about, but what about risk compensation? If you put people on, people who start using prep won't be careful in any other way, and sort of a very falsely moralistic approach. So how do you draw in when you get those clinicians who are, who sort of, their framework is so undeveloped for this, because we've had there's so little in our education about sex positivity, sexual health at all, let alone sex positivity. How do you engage when someone's not even at square one, but at square sort of -2?
So my opinion is that it's all about the relationship. So what have we done to build a relationship in order to get there to that conversation? So, and I'll use a good example. When we start off doing an academic detailing session, we have an introductory session where we just get to know each other, right? So it is about, this is who I am, this is my experience, this is the, this is my lived experience, but also this is my professional experience. And then we want to hear from them about what they're doing and challenges that they're having, but also like the good stuff that they're doing too, right? And so we want to really figure out how to break down those barriers before we ever start getting into sex positivity and taking on those challenging topics. If the person is already there, then great, we can continue having that conversation and move to the 201 or the 301 or the 401, right? But at the beginning, at the end of the day, it has to be beginning with a relationship first and establishing that rapport. And then I'll know whether they're ready for that conversation or not. And we can talk about the 5 Ps first and then add the 3 Ps as we go along. So if they're not even at the 5 Ps, for example, they're not sure how to do a sexual health history, then we can talk about that and then provide them the tools to be able to carry that further once they get the basics down.
Great question and great answer. Thank you so much. Rocco, we will triage any other questions that come in and bounce them over to you. So much juicy stuff. Next time, we're going to have to make this more breathable for all presenters. So thank you so much for being here. I'm going to turn it over to Anna to introduce our final presentation for this segment. And I will say that we will bleed about 3 minutes into our break so that everybody has the same amount of time. Over to you, Anna, to introduce Nadia.
Thank you, Bevan, and thank you, Rocco. As Anshul put into the chat, I had the pleasure of interviewing Rocco recently for our details blog, so you can view that blog on the link in the chat. Our final speaker of this session is joining us from Washington, D.C. Veterans Affairs Medical Center. I am thrilled to introduce Nadia Jubran. Nadia is a board-certified pharmacist in ambulatory care and serves as a clinical pharmacy practitioner where she specializes in academic detailing and pain management. As an academic detailer, she spends her time developing and socializing local initiatives with use of evidence-based medicine. She is going to share how her team has leveraged community partnerships to redesign care delivery for veterans. It is my pleasure to turn it over to Nadia to share more about this campaign. Nadia, over to you.
Thank you so much. I will go ahead and go to the next slide. I appreciate the introduction, so I don't take too much of our time. So if you guys could type in the chat box the first word that comes to your mind when you think of a veteran, that'll be very different from me, who has spent her career with Veteran Affairs, and I actually started at the age of 16 with DOD, seeing some awesome responses come through. And I think this of all of our veterans, truly heroes and unsupported. I can understand that, just a lot of great words coming through. many things that the VA tries to work with.
Yeah, lots of great stuff here, Nadia. Just a quick recap. We have homeless, neglected, heroes, seasoned, service, older, exhausted, tired, unsupported, respected, honorary, patriot, and brave. So we'll go on down. Oh, and we wrapped up with trauma, PTSD, trauma, and forgotten. Thanks, guys. Back to you, Nadia.
Thank you. And we can go to the next slide here. So just a brief overview of also my brief time with you guys. In today's discussion, I'm going to first walk through a common problem that we probably all have when detailing medical staff, and then review frameworks to approach potential solutions. And I'll review some successes I've had with these frameworks, and then close with potential directions I'm looking into and a summary slide. Next slide, please. So like I said, this is probably a problem that faces all of us. When I speak to medical staff, and I do that every day, I only work 1 day a week clinically still. So talking with staff every single day, and especially in the VA, we have a lot of directives, memos, things that are mandatory, and they pack an extra punch in the VA because they're usually subscribed into law. So I try not to, as a detailer, to come in with like, this is now a law, Congress is looking at us. Those are the implications, but also shaping it around patient care and really improving the care of veterans. But there are so many, they're nonstop at the VA. And I try to acknowledge that there's always something coming in. So we do have stressed out staff frequently. I think someone said yesterday, it's so hard. You go to providers or other medical staff and you're usually asking something of them versus you providing something to them. So I try to think about that with our stressed out staff. And then it also gets roped into these difficult to engage patients. So the directive or memo I'm going to talk about today that is our naloxone campaign. I don't know if many people recently saw, Veteran Affairs really leads the way in getting naloxone to veterans, as we recently distributed 1 million naloxone kits, and that's really due to our hardworking staff. But every year we do have directions, again, memos. This year it's really focused on getting naloxone in the hands of veterans who are using stimulants or using opioids, so stimulants being cocaine, methamphetamine. And these are patients who are difficult to engage. The literature has shown us that patients who are using these substances really engage in any medical center, not just the VA, for acute services. They're not coming for preventative care, for primary care. So the frequent barrier I get, whether that be naloxone or whether that be diabetes or heart failure, is that patient doesn't engage with me. Why are you talking to me about a patient who doesn't show up? And I really can't argue with that, because these patients don't show up. If we're looking at the beautiful data we have in the VA, these patients aren't coming to our front door. So it really had me start to think outside of the box and what we can do to engage those patients and take off the burden from our medical staff who keeps pushing back on why do we have these initiatives for patients who don't show up. Next slide, please. So again, these patients, focusing on naloxone patients, particularly patients who are currently using stimulants or using opioids, it really got to me thinking, in DC, in this area, we have so many great resources. Outside of work, I also volunteer at a harm reduction center. So thinking, these centers have been around since the 80s, since harm reduction really started, since syringe programs really started. So it got me thinking, why am I trying to reinvent the wheel? Why is the VA trying to reinvent the wheel in DC? And thinking about redesigning that care delivery. Why does the VA have to provide that care? Why can't I lead a veteran to that care? When it's being offered in the community, and even some of the speakers who talked previously, to be honest, the community is better at having those conversations about, if you're using, how do you safely use, and having those non-stigmatizing conversations. Of course, advocating for the VA to continue to have that training, but the community does it so well in DC. For example, in DC, we have a delivery service that you can call when you're using, and somebody will show up with supplies and a naloxone kit. So really, how can I compete with the fact that they will show up to exactly where you're at? I do want to introduce 2 frameworks for thinking about how to engage our community partnerships. The first one is referred to as MESH. That's multi-sectorial engagement for sustainable health. This is actually a framework used by the United Nations for worldwide health interventions. The image to the left is actually a screenshot from their MESH guide. And this involves working with for-profit businesses, nonprofit organizations, community members, and then us in the federal government. Now, when creating these partnerships, it's important to have mutual goals and not just be one person's vision. And that can be really hard for the federal government because we can be like very black and white. Living in DC, there is a joke that like, if you want to get a federal employee to do anything, to jump off a cliff, you put it in a directive because nobody answers any of these things. They just do them. So really taking a step back when you are doing these mesh initiatives to see what's important for everyone. One of my favorite examples is this image to the right. This is actually AB InBev's partnership with global governments. Now, AB InBev is a very big beer maker. They make Stella, one of my favorite beers. So looking at the initial global goal was to decrease unhealthy alcohol consumption. So you would think, okay, who are your stakeholders? You would never think that the maker of alcohol would be one of your stakeholders. But they actually are, because if their consumer is in treatment, if their consumer decides to stop using, they're not making that money. So it's really important to think about what they would see out of that. But that might shift, like for a federal government or for a health system, thinking of complete abstinence, but moving towards that harm reduction goal and engaging with the actual beer maker and figuring out how to decrease any unhealthy drinking. So another important thing to think about engaging this stakeholder is they have the audience you want. Thinking about how these patients are not engaging with the healthcare system. They're engaging with alcohol makers. So it's really important to think about out of the box stakeholders. Of course, it was brilliant to engage. There's actually a great video, if you guys look into this, of it's being done in Mexico City and some of their outcomes. Next slide, please. The next framework, one that I really looked to, was the asset-based community development. And this is looking in communities and figuring out what the community has and using that versus bringing in a resource to a community. So this is really what I did by looking and assessing the DC area and determining ways that we have to reach these veterans who are not engaging with us or who are engaging with us only for acute services. So this is a great framework. I will leave this as a resource for all of you, but to think about doing a full assessment of what your community has versus trying to build something for a community. Next slide, please. So one of the first things I did, we have a Southeast clinic, one of our VA clinics. Now, Southeast DC, for those unfamiliar with it, it's not the safest area. It's really a lot of the gentrification that's happened in DC, unfortunately pushed a lot of indigenous DC folks into the Southeast DC, making it more of an unsafe area and not having a lot of resources. But we do have a clinic out there. There's only one provider there that comes occasionally. The clinic has actually been connected with DC Access Housing, which is a NGO or a nonprofit organization that houses veterans. So they actually have housing for veterans inside the clinic. So it's essentially like the doctor shows up to their house because there's nothing there except for housing. And then a doctor has like one room that they can see patients in. So wanting to reach these patients, they're not coming to our healthcare system. So me and another colleague, we decided to go there and distribute the naloxone ourselves. Now, for anyone who works in pharmacy, especially in the government, there's a lot of red tape of like, well, no, you have to put a label on it and it's got to come out of the pharmacy. You got to put it in the computer system. So this picture right here is what me and another pharmacist colleague did. We printed off a ton of these labels and then hand wrote people's name in them. And we had a box or a bin of naloxone and just started scotch taping these labels on. When we went back to the pharmacy, we decided to process all of it through the computer. But really thinking and questioning every step of it. Why do they have to come to the pharmacy to pick up a life-saving product? Next slide, please. And then a month later, we went to a place that's referred to in DC as Conway House. This is actually like mixed income housing. As you can see from the slide, it mostly has veterans, homeless veterans that we're housing, but then it also does have several units that are associated with DC's Department of Health. So we also did another event here where we brought naloxone that we have, being able to give that to veterans on site by doing these handwritten labels. We also set up with like some coffee in the hallway, but we're also like, this is their house, this is the building. Like we were knocking on apartment doors and offering naloxone at their front door. It was really important to partner with DC Department of Health because there are people there that are not veterans, but they also really thanked us because they were giving naloxone kits to veterans there, and that was taking away from funding they have. So thinking about how also these partnerships can help the other community organizations. Next slide, please. And these are just some pictures from our events. Again, you see my computer there, I'm processing orders. We also have another pharmacist here with me, and we are handing out naloxone just on site. And it was really great to see. One of the comments here was like, this will help me save a life. There was a veteran who told me a story about someone actually overdosing on site in this apartment complex, and being able to offer that, you know, to another veteran, even being able to see that. Next slide. And then thinking not just community organizations, but breaking that down of who I could reach out to. There's me, the academic detailer. In the VA, we also have our PMOP coordinators, or our coordinators that focus on pain management, opioid safety. That was the other pharmacist in the image with me. We have our social worker that is embedded into the Conway House. Embedded, she frequents there to meet with veterans. So I reached out to her, figuring out the best way. You know, she mentioned going to apartment doors, which she frequently does to get in touch with people. So it's great to have her versus me, someone nobody knows, and showing up at your front doorstep. And then DC Department of Health, again, I didn't realize they were giving kits to veterans that weren't coming to us. And they were like, this is so great because that's limited our funding trying to get this naloxone when we acquire it at no cost currently. And then DC Access Housing, they provide housing for veterans in our Southeast clinic. Yes, you can go next. And I've really looked this year into expanding into some other partnerships, not just naloxone, but offering other harm reduction measures to veterans, such as syringe services, other safe drug use services. I think it's going to be really important to engage with. I currently am in talks with one of our mobile sites. We have in DC a mobile van that drives around passing out these, trying to figure out a place that would best serve veterans, and working with them to have a mobile site there. And then doing some more on foot outreach. I think it was just awesome being able to get out of the hospital, this hospital behind me, and start showing up at people's doorstep and offering them life-saving medication. And again, I didn't get to go too much into these frameworks, but here's information in that AB InBev story about engaging them is super powerful. And yeah, you can go to the last one.
And you'll see these links right in the chat box, so you can click on them and learn more.
Yes, and in summary, to think outside the box, like, again, I got a lot of pushback from pharmacy on like, you got to give the med right out of the pharmacy right there, but offering solutions, figuring out how to make it work, looking to other partners in the community, not trying to reinvent the wheel yourself. And then one thing I didn't get to in the asset-based framework is really engaging the community and figuring out how and where they want to be met. It's really important to have those conversations. Thank you.
Thank you, Nadia. Thank you, of course, for squeezing in. We will make a mental note next year to have more breathability, but that was a lovely presentation, and we have time for one question from Mike. You described how working with a corporate partner can be controversial. What kind of guardrails do you put in place for developing and delivering your message? Recent evidence points to alcohol use being unhealthy at any level, as opposed to the traditional message that moderate drinking is healthy. But that message could be tough on the partnership. So any thoughts about that?
Yeah, and it's such a hard space for me. There's probably more I wish I could do in the federal government, but there there are a lot of guardrails that I would have if I had to create that partnership. It would make it more challenging. But particularly like talking about alcohol use, like you mentioned, I think it is important, like we do with detailing, to take wins where you see them. Thinking about how that alcohol maker has your audience. So even decreasing some form of use and then progressing that message on your own would be really important. So one thing AB InBev really did, they really said loudly, we're partnering with these organizations, and then maybe you can grasp onto those audience. But I do think it's unrealistic to be able to capture their audience without meeting somewhere in the middle. So I think sharing that is fine, and then you deliver your own message because you are a health entity. But figuring out how to make some of those initial conversations happen together and capitalizing on that, I think is super powerful, because at the end of the day, your consumer is going to understand. It reminds me about the VA, like veterans will ask about cannabis use, even though it's legal in my state. Federally, it's not legal, and I can't really talk about it. And they understand that as a federal entity.
Thank you, Nadia. And thanks, Mike, for the question. Really appreciate all three of you, well, all four of you and your presentation so much. Thank you, Dr. Bloom. Thank you, Sophia. Thank you, Nadia. And thank you, Rocco, for really bringing in this concept of what are the patients feeling, thinking, and what do they need? Without further ado, we want to make sure we don't eat too much into your break. So don't forget, you're going to have a half an hour. Breakouts will run from 1:45 to 3:15. Anshul will be popping breakout information in the chat, and you can also visit narcad.org/breakouts. Choose from there, and then we will see you in our little workshops, and come on back for another break and close out the day. So thank you so much. Take your break. Thank you again to all of our presenters.
Over the next hour. Thanks, Anshul. And when Bevan returns, we will get started. So we are going to spend the next hour networking with your peers and continuing to build the relationships that you've all built with one another over the past 2 days during our inclusivity roundtable. Hey, Bevan. We are going to create a resource together over the next hour, and we'll tell you more about that resource and what we're planning to create in just a moment. Bevan, over to you to give a little more context of what to expect and briefly introduce the NaRCAD facilitators. Are you having any tech issues, Bevan? I see a message from Bevan. She is having some tech issues. So let me share my screen and we will take off. Give me 1 second, everyone. Okay. Can everyone see this screen? Good. All right, beautiful. Bevan, when you return, let us know, but we will get started. So we are leading today's session, Bevan, myself, and Anshul. You have met us all over the past 2 days, so we won't do introductions again, but we are here for you as we guide you through this session. So our role at NaRCAD is to continue to make intentional space for all of you in the AD community to discuss topics like inclusivity and stigma and bias. And we want to provide resources and foster connections for the detailing community to be collectively empowered to address clinician stigma when they experience it in the field. We also want to help you set realistic expectations about a detailer's role in navigating clinician stigma. Anshul is going to tell you about the goals of today's session. Anshul, over to you.
All right, so during today's roundtable session, we'll start off by exploring the challenges of healthcare stigma and detailing, and also share some of the results from NaRCAD Stigma Focus Group. Then you'll head into breakouts where you'll have the opportunity to collaborate with peers and co-create scripts on navigating stigma in healthcare. So we'll talk more about what that's going to look like in a moment. And then after that, we'll come back to the main room, reflect on those discussions, and start creating that tool together.
Awesome. Thanks, Anshul. All right, a few chat waterfalls to get us started. So type in the chat box, when patients are stigmatized in healthcare settings, what's the effect on the patient? Because remember, the summit, we're putting the patient experience first. So we want to think about that. Withdraw from care, less likely to seek care, mistrust, withdrawal, distance, lack of treatment, marginalization, shame, disrespected, trauma, poor quality of care, less options presented. We have feeling unheard, mental health issues, mistrust in healthcare. Sorry, I lost my spot for a second. Worse care, dehumanized, defensive, withdrawal, lonely, defensive, lack of engaging subject to misinformation, medical decline, and poor health comes in the future. So these are not great things that happen and when patients feel that they are stigmatized. And I see another one coming in, delayed care or avoid. So moving into our next chat waterfall, we have you're detailing a clinician who uses stigmatizing language about their patients. As the detailer, thinking as the detailer rather than the patient now, how do you feel? And I'm seeing some other ones from our last chat, disenfranchised and lead to depression. So thank you for those. Mandy's saying they're uneducated, sad. I want to react immediately. From Elizabeth, awkward, uncomfortable, frustrated, conflicted, uncomfortable, angry, another one for angry, annoyed, yeah, disappointed, baffled. Yeah, sometimes you just have to make sure your face isn't showing it all because you're just in shock of what's happening in front of you. Ready to educate, appalled. So these are all important responses in thinking about how a detailer may feel during a visit when a clinician uses stigmatizing language. We want to help you be able to work through these feelings and respond in a meaningful way. So at NaRCAD, and I have one more from MJ, spend a mindful moment. Yeah, just taking a second for yourself before responding. So our team at NaRCAD conducted stigma focus groups with detailers in the community to better understand their experiences with clinician stigma. We conducted these a few years ago, but we wanted to use this data to ground our conversation today. So we held 2 focus groups for 2 hours each. 10 detailers participated with 5 detailers per focus group. And the detailers were working on various clinical topics. We had detailers working on opioid safety, substance use disorders, HIV prevention, pediatric care, mental health, diabetes, and chronic illness. So we're going to tell you a little bit about the themes that came out of those focus groups, which overlap with some of the things you were all just typing in the chat box. So here are some of our themes. We had clinician denial of the impact of the clinical topic on the patient population. People said they've heard clinicians say, I don't have time for these kinds of patients, or I don't have those kinds of patients. That doesn't happen in my practice. That doesn't happen here. Clinician resistance to clinical change. I don't want those kinds of patients here. I don't want them in my waiting room. I don't want them in my clinic. I don't want to be known as the gay doctor if they're prescribing PrEP. Clinician concern of enabling patient behaviors, and clinician discomfort discussing certain clinical topics with patients like sexual histories or substance use. So those were some of the themes that we saw in our focus groups, and I am going to turn it over to Anjal to talk a little bit about the detailer reactions. Anjal, over to you.
All right, so these are some of the reactions detailers had said they felt during these conversations that they had with the clinician. So as you can see here, they felt uncomfortable, caught off guard, angry, shocked, and defensive. So I'll pass it to Anna to talk about some of the resources that were brainstormed during the focus groups.
Thanks, Anjal. So we asked people during the focus group to brainstorm some resources that would be helpful to support them when they interact with stigma during a detailing visit. So they came up with several examples here. Role plays, so doing additional role play sessions, either with the NaRCAD team or with their own team members to practice and work through certain scenarios. Connecting with peers in their own program or throughout the detailing community, using self-assessment tools for themselves before they go into a detailing visit, or sharing self-assessment tools with the clinicians so the clinicians can use those. Resources for leadership buy-in, literature, they wanted more evidence and literature, and I'm happy to say that since these focus groups, Anjal has created an inclusivity toolkit for us, and there is all sorts of literature on there that you can see. They also suggested pre-visit surveys with the clinicians, more conference presentations, and also scripting tools. So we've incorporated a lot of these suggestions into our work at NaRCAD, but we'd really like to get input from the people who are on the ground and in the field doing this work, which is all of you. So we are going to ask you to help us help you by writing the script. So we're going to place you all in breakout groups of 4 to 5 peers, and you'll be able to share solutions and start building the script with each other. Please encourage others to share ideas if you notice quiet participants. If your group is having trouble starting the conversation, have everyone introduce themselves or speak in alphabetical order. Hello, Bevan. I see that you've returned from your tech glitch. Good to see you. Perfect timing. Oh, you're on mute.
Yes, I had video problems and they are now resolved. So I will catch up on all the great stuff in the chat box while you guys are in your breakout groups.
Perfect. Thanks, Bevan. So we are going to show you now the stigmatizing comments that we want you to brainstorm responses to while you're in your breakouts. So Bevan, since you're back with us, if you want to share the first stigmatizing comment here, that would be lovely.
All right, guys, here we go. So here's the first thing we want you guys to think about responding to in purple here. I can't believe patients keep coming back without having lost weight. They're clearly not trying hard enough and not making healthy food choices. All right, number 2, Anna.
Yeah, the second one we want you to come up with some responses to is, I don't want those patients at my practice. They're so difficult to handle and are really just looking for another opioid prescription. Treatment won't work for them.
All right, number 3. Oh, I'm so tired of keeping up with all these different pronouns. You're either a man or a woman. Gets in the way of providing care.
Okay, and the last one, I don't need to use an assessment tool. I can always tell when someone's at high risk for contracting HIV. So
all right, these are pretty yucky. I'm gonna ask you how you think you should respond. Next slide.
All right. So Anjal put these comments into the chat box. So you'll have 25 minutes to meet with each other, come up with some responses as a detailer if you encountered this during a detailing visit. So with that being said, Anjal, it is, I think we're ready to open our breakout rooms.
Try to come up with full sentence responses, something that someone could read aloud. And try to have some fun with it. You can make up some fake answers if you need to get a little bit of anger out. We'll see you in a bit. Please take.
All right, looks like everyone is back in our room. Hope you enjoyed your breakouts. So now is the time we're gonna put all our brains together and create a scripting tool. So we're just gonna take from what all of you brainstormed over the past 25 minutes and write it right onto this document. Bevan, do you want to take it away with the first statement from the fat phobic clinician?
Yes, I will. Welcome back, everybody. Get ready to be over at your chat box. I'm going to do my best to keep up with you all. What are some things we can say? Yes, we will share this document with you, Miglena. What are some things we can say to the person who said, ugh, I can't believe patients keep coming back without having lost weight. They're not trying hard enough and they're not making healthy food choices. Give it to me. What can we say? Go ahead and chat, type that right in. Great one.
All right, I'll read them out loud, Bevan, and
Thank
you
you.
can capture them. Why do you think that is? What strategies have you already suggested that your patient has tried? Could there be other contributing factors that you haven't considered? Have you had individuals who were successful? What has worked for them? Tell me what types of resources are available in your area to assist patients in losing weight. It can be really frustrating when you're trying to help your patients and not seeing results or meeting goals. What are some of the barriers you think your patients are encountering? I really like that one because we started with a statement and then asked a needs assessment question for it. Another one from Dima, it seems like you're really passionate about helping your patients. I commend you for that. Ooh, I like that. What resources can I provide to help you and your patients see results? A lot of folks don't know what healthy food choices are. What barriers does your patient have to make your suggested changes? What can we do better to support these patients? I like the we language there. I hear what you're saying. I've heard that from other providers. What has helped them is, I really like that because now you're saying, yeah, I hear you. Also, I've had this come up before, and clinicians sometimes like to hear what their peers are going through. I understand your frustration. What works for you? Do you notice anything patients that say that have in common? Nicole says, reflect back. You work on some patients losing weight and despite people not having success. Weight loss is really hard. What strategies are your patients using? What tools and apps have you suggested that your patients use? I'm having a great job keeping up with all of these.
Doing my best.
Insert name of resources. Have you shared this with your patients? What other clinical considerations could be impacting their weight loss success? Plant a seed of doubt in the taken health or empathy. We never really know what's going on below the surface. Life events, food insecurity, and options. A few more
Love
here.
that.
Food costs have gone up and it's sometimes more expensive to eat healthy. Yeah, groceries are expensive. It's hard to start and maintain good habits. It is our goal to teach them how to get there and support them. Ooh, how are you managing relapse? I like that. So that actually is opening a needs assessment question, and that's digging even deeper. So maybe that's a question you ask a clinician a little further into the conversation. Two more here. Ask what you do currently with these patients and share stats on challenges and attempts to succeed with change. It can be frustrating when it looks like our patients are not listening to our guidance. How can you support the patient by telling them to supplement their diet, not restrict it, such as higher protein intake or weight training? What does the food environment look like in their area? In a food desert, food swap.
Yeah. All good stuff. I noticed that you are all very cautious not to push back on the stigma. And I think there's a fine line, right? You don't want to say, well, that was an incredibly stigmatizing comment. I loved the tell me why that is, right? There's a neutral way to kind of say, why do you feel that way? I think another way, and you guys can tell me whether you think this is a good or bad idea, because you're the detailers, that you could consider approaching it is saying, it sounds like, and just say it back to them. It sounds like you're saying that your patients aren't trying hard enough. Why do you think that is? Or in what ways would you like to see them try something different, right? So just having them hear their own stigmatizing comment, or saying, what are you asking them to do? And why do you think they're unable to do it? So really asking them, are you giving them the tools for success? So just some thoughts there. Great job, guys. All right, Anna, script number 2. What do we see?
All right, so this was the comment. I don't want those patients at my practice. They're so difficult to handle and are really just looking for another opioid prescription. Treatment won't work for them. So this is the substance use stigmatizer. What did we come up with? I see what you're saying. Can you elaborate on that? I'm curious as to what types of treatments you've tried that have failed. Julia says, I suspect you already have those patients in your practice. Only 1 in blank statistic patients with OUD actually receive treatment. It is so important to support patients in need. I understand that barrier. Can I provide you with resources to some place that you can refer your patients to? Tell me more about patients you've had with addiction in the past. What aspects of patient care make these patients a challenge for you? Yeah, asking about like the workflow. Can you share a bit more about your experience referring OUD patients for treatment? Do you have thoughts about what might influence treatment ineffectiveness? What treatments have you tried in the past? What do you think these patients need? What are signs of misuse that you're looking for now? Do you partner with substance facilities that might offer additional treatment options for your patients? Address the term those patients. So Nicole's pushing back a little bit, Evan. When you say those patients,
what do
help
you
me understand
mean?
what you mean? Able to address the terminology going forward and having a frank and honest conversation. It can be hard to help a patient that has whole health needs you aren't able to provide. Have you been able to get this patient connected to mental health or social services? How can peer specialists or advocates in your practice help this patient feel less alone in their recovery?
Love that.
And that's on the patient experience. I like that. What has been your experience with patients with buprenorphine? And finally, feel, felt, found story. Oh, I like this, Nicole. I can see how you feel. I had a provider who felt that way too. And when he started providing Suboxone, he found it was effective and also really valuable in supporting and developing the relationship with the patient and getting some traction into the whole health approach. The
Love
important
this.
pushback was the brave Zach Dumont.
Wonderful. And Takesha says, we have a peer team who could assist you. These are all great. And I particularly loved, Nicole, you saying, tell me what you mean by that term. So that's something you could use in any situation where something feels stigmatizing. Oh, they're not trying hard enough. Tell me what you mean by that. Help me understand, regardless of clinical topic. All right, let's get to number 3. And we have a couple more things. Oh, Dima, you're ahead of me. The closed-minded clinician, excuse me. Okay. The closed-minded clinician, I'm so tired of keeping up with all these different pronouns. You're either a man or a woman. It gets in the way of providing care. All right, take it away, Anna.
All right, Dima says it can feel uncomfortable at first because it does require a learning process. I'm happy to provide resources to make the process easier. It can be easy to confuse gender with sex. What does it get in the way of why does it get in the way of providing care? There are resources available that can help guide you to use the correct pronouns. That is interesting. How does that make providing care more difficult? Continue the conversation using appropriate pronouns. Maybe they will change their approach. Yeah, using language that the clinician can mimic is often really helpful. No problem, Dima. I think it could help you provide care to your patient. Asking them what they are comfortable with will speak more openly. This will result in better care. What aspects of providing care make it more challenging? Show empathy, step in their shoes. Just with everything in science and medicine, change can be hard, but it happens for a reason as we learn and grow. Provide examples for relevance, importance, statistics, evidence. Can you tell me how you find it gets in the way of care? Have you had a bad experience in the past?
I love that.
How does connecting with a patient look like to you? Or what does that look like? What about pronouns makes your care challenging? So on the one hand, you find the idea of using pronouns a challenge, yet on the other hand, you want to make connections to your patients. So I'm seeing some pushback here now. What are your thoughts about asking patients if it's okay to use first names? I hear your frustration. A lot has changed in a short amount of time. Using preferred pronouns helps improve care. It's also patient focused. And we have a final one. It may be confusing at first, but it helps with individualized care. And it overall makes the patient feel seen.
Beautiful, guys. This is wonderful. And again, don't forget, in any of these situations, data is your friend. So look, these stats show that patients who used different pronouns, I'm pulling this out of the air, built more trust when their pronouns were accurately used, or when their clinicians asked them what their pronouns were, something like that. Excellent work. Let's go on to the final one. Anna, take it away.
All right, the comment is, I don't need to use an assessment tool. I can always tell when someone's at high risk of contracting HIV.
Here we go. You guys are ready to go. I love it. Go ahead, Anna.
Use statistics to frame the conversation. Oh, I lost my spot. As you continue, is there someone in the office that does a more detailed screening? Look into what they're doing and opportunities to expand. Can you tell me more about that? Acknowledge their self-claimed skill. I'm sure the things you're already doing are built into these tools. There may be cases that are as obvious and would slip by without specifically asking the patient. Have you ever had anyone that slipped through the cracks? Tell me what that looks like. What do you look for? Tell me more. What questions are you asking? What barriers do you have to screening? Can you say more about your process of determining someone is at high risk? It's important to take a good sexual health history on all patients. An assessment tool ensures you aren't missing any key points. Can you elaborate? How do you make that determination? Since HIV is not always only contracted via high-risk behaviors, can you share with me what you think makes a patient high risk without using an assessment tool?
Yeah, love that.
Here's a good one from Charles. How long have you had these supernatural powers? Have you used
Charles,
any validated screening tools to assess for HIV? Many patients with HIV may appear healthy, but require immediate medical attention.
Excellent. Any more, guys? I really want to put Charles in here. All right, couple more.
Magdalena just sent a bunch. A person's looks or identities are not enough for us to fully understand what sex they engage in. There are biological factors that can help us better understand a person's level of risk of acquiring HIV, such as anal sex being higher risk in comparison to vaginal sex due to the sexual act leading to micro cuts, and has nothing to do with a person's identity. This seems like a great opportunity for your MAs or intake questionnaires to ask these sexual health history questions. If you're short on time. Different kinds of sex have differing risk of transmission. And Elizabeth just sent a whole bunch too. Thank you, Elizabeth.
Wow.
I'm going to pull out
Love
some.
this. I'm going to pop it all down here.
Yes.
All
I'm going
right.
to read out like 3 of them. I'm surprised to hear you say that. You've always supported equity, and this doesn't sound like you at all to me. So this one would be good for a clinician that you've worked with before. I don't think we should make statements that imply females can't make it in science because of family responsibilities. That assumes a lot of stereotypes about both men and women.
Oh, so these are across all kinds of different things. Gotcha, gotcha. Great. Let's pull out a couple that you could apply to anything. Like I'm thinking, I'm really uncomfortable or disappointed by this comment. That's a great, I'm really uncomfortable with that comment. You know, what's wrong with saying that, you know, or I want to come back. How about the weather we're having? Yeah, so asking probing questions. Yeah, these are all great. These are all great. I'm going to keep these at the bottom here to be applied to any situation, and we'll go through. You guys are amazing. Just want to walk you through what you all came up with in like 15 minutes. All right, so here is a 5-page tool. Okay, writing the script, how to respond to fat phobia. Many of these things don't just apply to that. I hear what you're saying. I understand your frustration. A lot of folks don't know about X. It seems like you're passionate. These are great. We have some for substance use disorder. We have some for really just either specifically being closed-minded to gender affirming care or, you know, using appropriate pronouns, and then folks who are presumptuous. So many wonderful things. You guys get a huge round of applause from us. Thank you. Anna, did I miss anything else?
I don't think so. You did an excellent job grabbing all of that, and we will post that on the website.
We will. We're going to clean it up. We have all of your names of who is in the room at this time. We're happy to put your names as authors on this document. If you would like us to omit your name, please email Anshul, or else we will go ahead and say Miglena was one of the 50 authors in the room. And Elizabeth says, our team would like to nominate Tina from Illinois Advance for the NaRCAD Friday Afternoon Energy Award. Yes, those of you who have energy at 4:45 or 4:44 ET, incredible. We're a little behind on wrap up, but we can go ahead and do that now. Anna, I am happy to pull that up if you have no objections.
No objections.
All right. So here we go. And we will take it away. Congratulations, you are officially an Inclusivity Toolkit author, unless you tell us you don't want to be. Over to Anshul to talk about what this toolkit is and encourage you to check it out.
Yeah, thanks, Bevan. So this is a toolkit that we recently launched back in November, and we're so excited to include this resource you all curated, as well as others that were shared throughout the summit these past 2 days. But this is our current inclusivity toolkit. On the left-hand side, we have resources on implicit bias, cultural humility, communication strategies, and best practices that we've heard from our detailing community. And if you're looking for more clinical topic specific resources, maybe literature and other communication strategies, we have 3 clinical topic groups, substance use disorders, HIV prevention, and mental health currently. And again, we're so excited to continue to include resources on here. It's a growing toolkit. So if you're looking for a particular resource, or maybe your program has a resource that you'd like to see included on here, please don't hesitate to reach out to us.
All right, Anna, let's take this part away.
All right, so we are going to walk through some of the resources we have at NaRCAD. Please reach out to us if you want to connect or need tips, guidance, assistance as you're continuing to build your detailing program. We are funded to help all of you, so please do reach out. It is free. Anshul, if anyone missed sessions at the summit or wants to rewatch content or look at these awesome tools and worksheets that we created, where can they find all of that?
Yeah, so definitely keep an eye out for our AD Summit Hub page, where, as Anna mentioned, we'll include all the main session recordings, slide decks, resources, all on here. So the page will be live by the end of next week. So I'll pop a link to our current Summit Hub page, but the link, once it's live, will be available there.
All right, up next. So as Anna mentioned, we are here to help you with a variety of different supports, and they are, as she said, free. We have virtual support. Again, check out our amazing Anshul curated customized toolkits, presentations, webinars, and more. We're here to get on the old-fashioned telephone or a Zoom to help you with visits, data tracking, planning, looking at materials. We also offer unlimited guidance via email, resource requests, troubleshooting, and all that good stuff. Anna, over to you.
All right, so as of right now, you've all been added to our mailing list so that you can keep up to date on our offerings and events. If you'd like to opt out, please message Anshul or you can email her. We never spam you. We only send things you need to know that are happening in the AD community. And we are going to walk through some additional resources from our beautiful website. Bevan, over to you.
So, yeah, thank you. Check out narcad.org if you haven't gotten friendly with it yet. It'll be one of your best pals as you move through your detailing journey. And here is one of my favorite landing pages that Anshul has created. It's our program planning hub. Anshul, let's walk people through that.
Yeah, so if you've been on our materials toolkit page, it's essentially the same materials on this hub. Resources from other academic detailing programs on what's worked for them. Maybe you're looking for an example of a flyer or an evaluation guideline or anything related to academic detailing programs. It's all available on here, as well as some guidelines from our NaRCAD team as well. But definitely check this page out if you're looking for some more resources.
All right, here's some cool new blogs that are also in our program book from Anna. Anna, tell us about these exciting stories that I know you were really eager to promote and to share.
Yeah, so Anshul and I co-manage our blog. We share stories from the field. We've been shifting the focus of some of our recent blogs to the patient experience and incorporating the patient voice. So we have a blog with Rocco Cook, who presented earlier today. And he shares about his detailing work and his experience with HIV. We have a blog, a patient story of an experience with substance use disorder and the story of recovery. And also we have a final blog that just got released this week with a colleague in New Hampshire who shares their work on harm reduction and how they've been detailing policymakers, a whole new realm of people outside of primary care to detail. So I encourage you to check that out and see what work they are up to. And also these are in the program book, as Bevan mentioned, but you can also look at our website and see these blogs and all the blogs we've ever posted right on our website.
And what I love about these pieces too is especially this middle one about the person with substance use disorder is there's an AD emphasis. There's still that AD lens of what would that person have wished a clinician had been able to provide them. So again, we're looking at patient voices, but we're always trying to tie it right back in to detailing. And we're always trying to include you as well. So Anshul's going to walk you through what our community check-ins look like. And for those of you who have already joined us, for those, you know that they're a lot of fun. Over to you, Anshul.
Yeah, so our community check-ins are really fun and engaging. It's an opportunity for everyone in the detailing community to come together, collaborate in small breakout groups. And we've done various different topics, such as you can see here, speaking to leadership, empathy, patient experience, and we have one coming up in July. So stay tuned for some more information about that soon.
All right, and we'd like to announce our last training of 2023. This will be a virtual training on September 26th through the 28th from 1 to 5 p.m. Eastern daily. Mark your calendars. Registration opens July 3rd at 12 p.m. Eastern. You can learn more about this training on our website, and we hope to see you there. And stay tuned for later this year for an announcement about our 2024 trainings.
Can you believe it's 2024? I feel like we are in such a future that these numbers just made me feel like maybe we would be living in outer space. So come with us to NaRCAD 2023. Those of you who have been to our annual international conference series have really been so lovely and participating and drumming up new ideas and getting to meet each other. And delightfully enough, this is the first time, except the past 3 years being virtual, this is the first time we'll be back to in person with live stream available. We've been accepting proposals and getting lots of juicy stuff. We decided to extend it for 10 or so more days, more like 8 or 9. So please go ahead and go to our website. Anshul just dropped the conference series link, as well as a lot of other awesome nuggets in the chat box. If you're not sure if you're ready to present now, but you have some ideas or some seeds in your mind, or you'd like to be on a panel but you don't know anyone to join with, things like that, please email us or propose something that's halfway done and we'll help you figure out how to finish the other half. Don't be shy. This isn't a classic research conference where you have to have all your numbers in a row to apply. So please do join us for that. And we're going to throw it over to Anshul to close us up with a thanks to our sponsors and everyone who spoke at our conference.
Thanks, Bevan. So yeah, as we come closer to the end of the summit, we first would love to give a big thank you to all of our presenters and partners. Your collaboration and expertise has really helped and made this event come to life. And we are just so grateful for your continued partnership and contributions.
Special thanks to AHRQ for funding us for the past 10 or so years of our conference. And this is the first time that they have funded us for a mid-year event like the summit. So getting feedback from you is going to really help us learn if this is a worthwhile event to continue. We'll give you the eval link in just a second, but we want to close up together, all of us from the home team. I'll start us off by saying thank you so much for being here. We've been beyond excited, not only leading up to this summit, but during the past 2 days, we couldn't be more delighted with how involved you all were, with all your amazing thoughts and the things you created that are now part of our community's resources. So thank you so much for that. I'm going to turn it over to Anshul to say bye, then to Anna, and then we'll close up with our fearless leader, Mike Fisher.
Thanks, Bevan. Totally agree. Thank you all for the last 2 days, for your participation and engagement, and for staying with us still on a Friday evening. So thank you again, and please continue to keep in touch. I'll pass it to Anna.
Thank you. And thank you, everyone. I feel so lucky to be part of this incredible community. Keep doing the terrific work that you're all doing. This is important work, and you're all making an impact on our communities. I have so much respect for each and every one of you. So thank you to our attendees, our presenters, and our funders. What an absolute pleasure it's been to learn and work alongside all of you the past 2 days. So take care, and hopefully we'll see you in November in Boston.
Over to you, Mike, for some words of wisdom, so don't mess it up.
No pressure. Well, thankfully I get to take the mic when the pressure is off, because our team and all of you together have delivered an amazing 2 days worth of sessions, and it is just so so wonderful to see what everybody together can accomplish with tremendous leadership by Bevan, by Anna, by Anshul, the way that this community has come together despite 3+ very difficult years and has found new ways to grow. So that, as Bevan said, we've tried this new mid-year summit. We're really eager for your feedback. Again, I am so appreciative of our core team who had the vision to develop this and to make it its own distinct thing that was different from the conference and added to our sense of community and what we can do. So thank you, as Bevan said, to AHRQ for funding us, both our core funding and for the grant, the conference series, and now this. Thanks to all of you for the energy and commitment, and we really want to hear from you. We would love, this summit to be a chance for us to be innovative every year and creative, and to build on the innovation and creativity that we saw these last 2 days. So have a lovely weekend. Those of you who are not on the East Coast, I guess you have to still, earn your nickel for a few more hours until you can enjoy the weekend, but whenever it comes, enjoy it. And thank you so much for being a part of this.
Thank you, guys. Please fill out our survey. It'll just take you a few minutes and we can enter you into a raffle to win $250. So get that paper and tell us what you think. You can be anonymous and we will take everything you have to say into consideration. Thank you, guys. Take care. Once you have your link, feel free to sign off. Thanks for all the thanks, guys.